Good morning, good afternoon to everyone, and welcome. My name is Ernesto Otero. I'm a professor of ophthalmology at the Barraquer Institute in Bogota, Colombia. And we're gonna talk today about the surgical approach to dense cataracts. These are my financial relationships, none of them related to this presentation. So how do we classify cataracts? And there are various classifications around the world. The one that I like the most is the Barraquer classification by Rafael Barraquer in Barcelona. And the reason I like it the most is because it gives us an idea of the density of the nucleus. And it's classified from 1 to 10. And it correlates with the LOX classification system in the sense that the N1 and N2 are the LOX 1, the N3 and N4 correlate with the LOX 2, the N5 and N6 with the LOX 3, N7 it's a LOX 4, and then we have the N8, which is a rubra cataract or red cataract. Then we have the N9, which is a brunescent cataract or a brown cataract, and N10 is a black cataract. So as you can see, this gives us an idea of the hardness of the nucleus. It'll help us orient the treatment of our patients based on the hardness or the density of the nucleus. So when we talk about dense cataracts, basically we are talking about N7 and N8, N9 and N10. That means a LOX 4, a red cataract, a brown cataract, or a black cataract. So what are the challenges with hard nuclei? Basically, there are two main challenges. One is minimizing the damage to the endothelial cells. Because these cataracts are so hard, we're gonna need lots amount of energy. We're going to be manipulating inside of the anterior chamber, and hence we have to again limit the amount of energy in the eye, and we need to protect the endothelium. And the other challenge with dense nuclei is disassembling the nucleus, because it's so dense that fracturing it is sometimes difficult and hard to achieve. So what is the pathophysiology of endothelial cell damage during cataract surgery? First is a mechanic trauma. We can traumatize the endothelium with irrigation fluids if we have a misdirection of our cannulas hitting the endothelium. We have trauma through tumbling of pieces when they're flowing inside of the anterior chamber. They can bounce back and forth, damaging our endothelium, or we can inadvertently traumatize the endothelium with our instruments, be it with a phaco tip or with the intraocular lens or with our other instruments. And then there's a toxic trauma, which is basically TAS. TAS, as you all know, is toxic anterior segment shock syndrome, and basically is a chemical injury into the endothelium and the iris. It's really hard to know what causes it, but it's been thought that it could be caused by intraocular anesthetics, antibiotics, detergents, from the washing of the instruments, and preservatives. And these all can obviously decompensate the cornea and lead to an endothelial transplant. And then there's a thermal damage to the intraocular structures, which are caused by heat and energy. And this is a beautiful diagram by Alió in Spain, in which we see how liberation of free radicals basically produce initially a swelling of cells, and then shrinkage with damage to the chromosomes and the nuclei, producing endothelial cell apoptosis and death. So can we protect our endothelium? That's always the big question. Can we really take care of protecting the endothelial, and there are various studies that, experimental studies, that show how we can protect the endothelium. And the question next arises is, do viscoelastics really protect our intraocular structures? And the answer we'll see in a few minutes, but basically we have two types of viscoelastics. We have, as you know, cohesive viscoelastics, in which they have basically a higher viscosity. The chains of the viscoelastic are basically very small chains, and again, they adhere to the intraocular structures, and they are ideal in creating spaces and maintaining spaces. They're easy to insert and they're easy to remove, but again, because the chains are linked to one another, they basically produce less endothelial cell protections, as opposed to dispersive viscoelastics, in which the chains are again shorter. They have lower viscosity and they adhere much better to the tissues. They're harder to remove and they're harder to insert, but as they stay within the eye, obviously they help us protect the intraocular structures. And so here are various types of viscoelastics. We have dispersive, in which we have viscoat, cellugel, ocucoat. We have viscodispersive, which is a combination of viscous and dispersive viscoelastic, which is basically Discovis. We have cohesive, like Provis, Helon, and Anvis, and we have very cohesive, in which we are very good to form spaces, but are very dense, and again, very good to create spaces, but not so good to protect the endothelium. So again, by creating space within the eye, we have a greater range in our movements inside of the eye. And if we have a retained OVD and it adheres to the endothelium, then the risk of damage due to thermal energy is minimized. But what does the evidence show us? And basically, I'm going to show you three studies that will show us how the OVD is retained in the eye, how the OVDs protect from thermal damage, and how does the endothelial cells behave after the implantation of OVD. So this is a study, again, published in the Journal of Cataract and Refractive Surgery in December 2005, in which they made an assessment of the retention of different viscoelastic devices. It was done on New Zealand rabbits. They basically evaluated 6 OVDs. They did a phaco of the crystalline lens. Then once they finished, they injected silicone oil and then measured the distance with a confocal microscopy between the silicone oil and the endothelium. So if the OVD was retained within the eye, it would be easy to evaluate. And these are the results. Basically, here we see the cornea, we see the endothelium, and we see the silicone oil and the distance between the silicone oil and the endothelium. And we see that the viscoat, which is a dispersive viscoelastic, had 187 microns from the silicone oil to the endothelium, and the Discovis, which is a combination of cohesive and dispersive, basically it's a combination of viscoat and Provis, had 325 microns. So this study evidence that, again, if we use dispersive viscoelastic, it will be retained in the eye after phacoemulsification. And why do they think that it is retained? It is due to a negative electric charges of the OVD that basically adheres to the endothelium. The next study evaluates the thermal protection of the OVD. So basically, what they did is also evaluated in rabbits' eyes, evaluated 6 different types of OVD, and compared it to BSS at normal temperature and BSS at lower temperatures. Basically, what they did was remove the nucleus with the cortex. Then they filled the AC with OVD or BSS, inserted the phaco tip, and ultrasound and did ultrasound again. And with a thermal camera, they measured the temperature generated on the cornea and that dynamic increase of that temperature. And what the results showed was, here we can see in this graph, the pre-operative temperature and the temperature generated on the cornea with different type of OVDs, with BSS at 22 degrees centigrade and BSS at 4 degrees centigrade. And as you can see, the least temperature observed on the cornea when they introduced the tip and did ultrasound was with BSS at 4 degrees Celsius. And the second was dispersive viscoelastic. So that means that not only the OVDs are retained in the eye after emulsification, especially the dispersive OVDs, but also they limit the amount of heat that is transmitted to the cornea. And then the last study that I'm going to show you today is a study that evaluated two types of OVDs with a soft shell technique and the impact on the endothelial cells. And they evaluated the endothelial, not only the endothelial cells, the number and the endothelial cell count, but they also evaluated the central corneal thickness. As you know, if there is swelling, what we'll see, or if the cells are not working adequately, what we'll see is increase in the central corneal thickness. So they randomized it into groups, and here we see the outcomes. The pre-op corneal thickness, the post-op, as you can see, there's swelling, there's increase in the thickness at day 1. It starts reducing at day 7, and it goes basically back to normal baseline at day 30. And the group 2, which had a discovis, we see that basically the behavior is the same. And when evaluated the endothelial cell count, basically see the behavior using only dispersive or discovis is basically the same. We see the same number of cells and a very low variation between the two groups. So now we understand and we know that OVDs really protect the endothelium, and if we want to use, it's better for us to use dispersive viscoelastics, as they'll be able to limit the damage to the endothelial cells. Next is, what techniques should we use during or treating these very dense cataracts? And the consensus is that the most efficient techniques with these dense cataracts is to use phaco chop or chopping techniques. In the chopping techniques, basically what we do is follow the cleavage lines of the crystalline lens to fracture it and divide it, because the lens is so dense and so hard. If we basically find these cleavage lines, it'll be easy to fracture. Just as we do when fracturing wood, basically we don't have to go through and through in our wood. We just need to find the cleavage point, and then we're able to break it in different pieces. So the same happens with the crystalline lens, and there are two types of chopping techniques that we can use in these nuclei. The first being the horizontal chop technique, in which basically we embed with high vacuum, high energy, and low aspiration rate into the nucleus, and low flow rate into the nucleus. And once we grab and we have a good hold of our nuclei, we'll go with our chopper to the equator of the nuclei, and then bring our instrument towards the phaco tip, following those cleavage lines, and break it in different pieces. This is my preferred type of chopping in dense nuclei, as our movement is from the periphery to the center and not vertically, so that limits the damage or the strain on the zonules. The other technique is to do a vertical chop technique. So basically what we do is exactly the same. We embed our phaco tip in the nucleus, and then with a vertical chopper, this is a chopper that has a very fine and sharp point, we embed in the nucleus in the center, and we basically bring it together and make this a posterior and anterior movement to find the cleavage lines and break the nucleus in different pieces. So here's the technique that I use with this dense nuclei is a horizontal chop. So as you can see, I've removed the cortex and I embed myself in the nucleus, and we can see how I'm able to chop it in different pieces. So here I'm embedding, again, using low flow. We don't want to repel the segments, we just want to keep them there, and we're able to emulsify. And here, as you can see, we have this sentinel bubble that is always there, always still. So that is a sign that our dispersive viscoelastic is there and is working. If I had aspirated the viscoelastic, this bubble would be tumbling all around once we aspirate it. So we can see that the dispersive viscoelastic is well within the eye, because we see all these bubbles again staying still. And again, this is patience. You just have to grab pieces and go on fracturing them. So now let's see some videos, and I'm going to give you some tips of how to approach these cataracts. So this is our first case. As you can see, is a brunescent cataract, very dense. So it is very important, as I said, to use stain the capsule. These lenses tend to be so dense that there's very little or no red reflex. Then after staining, we inject our dispersive viscoelastic, first coating the endothelium, and then our cohesive viscoelastic to create what we call the soft shell technique. That cohesive viscoelastic will push the dispersive viscoelastic against the endothelium, and as we saw, due to different electric charges of chondroitin sulfate, it'll adhere adequately to the endothelium. Then we do a rhexis, and in these cases, it is very important to do large-sized rhexis. And the reason is because these nuclei, again, are so big within the bag, we need to have a good enough space to manipulate it. And because we're going underneath the anterior capsule to engage the equator of the nucleus, then we want it to be big. Generally 6 or 6.5 millimeters is good. In terms of hydrodissection, it is also important not to, because we won't see the wave going behind the nucleus because of the density. Then what we want is to just inject a little bit of fluid to liberate it, and then we're able to rotate it, and then we know that the nucleus, it has been separated from the capsular bag. So here, as I said, we embed ourselves in the center. We don't have to really go all that deep. A rule of thumb, if I find that the phaco tip embeds in the nucleus, then the probability that I can chop it is very, very high. So as you can see, again, we use high power, no torsional. It's very important not to use torsional, just longitudinal ultrasound if some of you have the possibility of having torsional, because we don't want to create a big hole. We just want to create a small hole that basically covers the phaco tip, so we can have good holding power, and we're able very slowly to chop it. We don't want also, or we don't want to have a high flow, as we don't want the flow of liquid into the eye pushing the nucleus posteriorly and again, separating it from our phaco tip. We want to be very, very efficient once we've fractured it in the pieces that we want. Again, we'll continue to fracture it in even smaller pieces, and that helps us limit the amount of ultrasound. Once we've done this, and as you can see, I have I've pulled the sleeve backwards when I'm doing the chop technique. Again, that allows that phaco tip to go deep into the nucleus. Once I've been able to fracture it, then I can proceed to chop in little pieces. And as you can see, I'm using the chopper to basically pressing it against the phaco tip with vacuum. And then once there's occlusion of the phaco tip, then I'll do ultrasound. This again limits the amount of ultrasound that we're doing. Again, there's no rush. You just don't sit in the center and start doing a lot of ultrasound. So you just always grab the pieces. Once the tip is occluded, we'll proceed to do the emulsification. At this stage, as you can see, we stop without removing the phaco tip, and then we inject of dispersive viscoelastic again, and that helps protect the endothelium. How often should I insert dispersive viscoelastic? As often as you want and as often as you feel comfortable. Generally, what I do in these dense cataracts is approximately every 3 of CDE. As you know, CDE is basically a measure of the energy disseminated. This measurement is generally used in the Alcan phaco machines. So every 3 of CDE, I'll use it. You can use it, or you can do it about every minute of phaco emulsification. That is acceptable. But again, err on the side of injecting more than injecting less. Then once we've removed the nucleus, the cataract goes as usual. In this case, as you can see, we had 9.78 of CDE, which is an excellent number. Generally, when I have cataracts that fall in the range of N3 to N6, I'll have around 3 to 5 of CDE, so 978 is very good. Generally, these dense cataracts, I expect to have around 17. So with this case, as you can see, I was very, very efficient with a phaco time of a total ultrasound time of 45 seconds. So these are very, very good numbers. And here I wanted to show you the parameters that I use. So generally, I use a high vacuum, 450 a vacuum. As you can see, it progresses. So as I push the foot pedal, it'll rise. The vacuum. I maintain an IOP of 70, and I have an aspiration, a high aspiration. I want those tips to flow into the phaco tip, and I don't want to be looking for them. I have 95% of torsional, so when it hits 95%, it'll send some bursts of longitudinal. That is because these phaco tips tend to occlude with the fragments as they are very, very dense. And using burst or using microburst, that'll help us with the efficiency of the ultrasound delivered into the eye. And this is the first day post-op of this patient. As you can see, it's a very nice and clear cornea. There's a little bit of edema up here next to the incision, but overall, it is a very nice and clear cornea. The other tip is it is very important to know when to convert. Some cases like this one are very dense cataracts. So when you have an older patient with such a dense cataract in a pupil, that doesn't dilate very well, you should suspect that there is sonular weakness. And this is something that you should always keep in mind. As you can see, this capsule is fibrotic. We see all these folds that are generated under the capsule. It is tough to do a rhexis in these cases because, again, that fibrosis is hard to manipulate. Sometimes we have to go around the area of fibrosis. We have to do it, again, very, very carefully. As you can see, it's a rhexis that it is very difficult to manipulate. Again, sometimes it's tough to do it as large as we want because it is adhere to the underlying cortex. And in these cases, again, trip and blue or staying the capsule with whatever you want is ideal. And again, very slowly, very gently manipulating. These cases are a real challenge because, again, they have a mixture of complexities, starting from the capsule, then you suspect that the sonule is weak, and as you can see, we did a fairly good job, or I did a fairly good job with the rhexis, a fairly good job liberating the nucleus, and as you can see, it doesn't look as dense as the other one. But then when I try to fracture it, it's very hard to fracture. It is very elastic. It's like, yeah, it's like gum, in which again it's really hard to find the cleavage points. And I'm gonna advance this a little bit. So again, as you can see, very tough to fracture. Even though I was able to embed myself, I'm not able to move it. And there you could see that when I was trying to, and I'm going to repeat this, when I was trying to fracture it, how the capsule and everything shifted, the whole bag and nucleus shifted to the center. So then I switch and I try to use the Akahoshi chopper to try to break it. And I see that it's really not fracturing. I'm not able to break it. Again, I'll give it another chance very slowly, because you look at the edge of the capsule, the blue capsule, that stain, how it moves when I try to bring it to the center. You can see how it moves toward the center, and that is a sign of a capsular weakness. So in these cases, again, the cemetery is full of heroes, so it's better. That's a saying that we have in Colombia, and so it's better to just put a little stitch on our incision, do a peritomy, a superior peritomy. I'm gonna advance this a little bit. So we do a superior peritomy, and then we basically luxate the nucleus into the AC, as I did, and then going right behind or posterior to our incision, we use the 15-degree blade to create an incision at the surgical limbus, and then we create a corneoscleral incision for us to convert to an extra cap. Again, it's always important to use our Westcott scissors and oriented or corneoscleral scissors, doing a 45-degree angle, and then with the loop, we'll just extract that nucleus. So here we've made a good choice, because we basically, if we kept on trying, we would most likely have a zonular dehiscence, vitreous in the AC, and our case would be complicated. And we just put some stitches, aspirate, and introduce a 3-piece IOL in the bag. So it's always important to know how to convert and know when to convert. Are there other options? Yeah, and I wanted to show you doing a flax or femtosecond laser cataract surgery in a dense nuclei. So the advantage of the femtosecond is that it basically helps us with the incision, it helps us with the rexes, and depending on the femtosecond that you have, there are various programs that create a fracture of the nucleus, either in squares or in fragments. You could do 4, you could do 8, you could do 16, basically making that nucleus less dense or pre-fracture, and that'll enable us to do orexis. One of the limits that I find when doing this is that in these very dense nuclei, the femtosecond has a tough time going through because of the opacity. The other thing that I find is that it tends to do the rexis based on the size of the pupil. So generally, although it's very predictable to do, it's very tough to get rexis as large as we want, because we're limited by the size of the pupil when we engage the femtosecond laser. And the other thing that I find with these cases is that generally they don't really crack the nucleus, or they really don't fracture the nucleus. As you'll see here, I tried to do eight fractures or 8 pieces, 8 pie pieces. And as you can see, basically what I have to do is go back and do my horizontal chop technique, because the lens is basically not fractured. Again, it works, yeah. Does it bring any added value in these cases? I don't think so. I'm gonna, again, move a little bit forward. And as you can see, I have to just go ahead and fracture it as I generally do until I'm able to fracture one of these pieces, and then I continue removing the lens. So if you don't have a femtosecond, again, don't even bother, because as I showed you, it really doesn't have a great added value in these cases. And the other technique I wanted to show you is in black cataracts. So there's always the question, can I do phacoemulsification in these black cataracts? And the answer is yes, but always prepare yourself. So as you saw, I used subtenance anesthesia, and I created a small peritomy. Why did I do this? Because there's a high chance, or a very high chance, that I might need to convert. So by doing my incision at the surgical limbus in that peritomy, if I have to convert, then simply what I'll do is complete the peritomy and then basically do a corneascular wound starting from the previous one that I did. And this is a beautiful case because, as you can see, I'm doing a very large rexis. Again, the denser, the larger the rexis that we should have. Again, don't feel afraid that when you implant the intraocular lens, it won't hold. It does hold a single piece IOL. And as you can see, as I said before, using dispersive viscoelastic initially, then cohesive, creating the soft shell, and then we gently go and start fracturing. If I see that I'm able to fracture the lens in these hard cataracts, I'll go on and continue with the case. Generally, the periphery is slightly softer, so always try to go from the periphery towards the center. And generally, the cataracts have a posterior leathery surface and in the posterior portion of the crystalline of the lens, so that we should leave for the end. And again, this is a game of patience in inserting dispersive viscoelastic And again, with a lot of patient going on, emulsifying, again, occluding the tip, and then doing ultrasound. And as you can see, we're leaving this last leathery portion till the end, and able to successfully emulsifying our cataract. Always the secret to success is using a lot of dispersive viscoelastic to protect the endothelium, because again, what purpose does it serve if we emulsify this nucleus, but then we end up with a endothelial transplant? And again, I wanted to show you how the lens holds in place. We can put it in the bag, and it generally will hold very well. Then we can close our incision, close our conjunctiva, and aspirate the viscoelastic. So again, we can do it always. If you find that it's not embedding, then you should convert. And this is the first day post-op. Again, a very nice and clear cornea. Looks very, very good. Again, thanks to using the dispersive viscoelastic. And there are other options. So don't always stick to doing phaco on these cases. That's why this is a surgical approach to dense cataracts, not to phaco of dense cataracts. So this is another case I wanted to show you. It's a Morganian cataract. So these Morganian cataracts, what we have is that the crystalline, the cortex is reabsorbed and it's liquefied, but the nucleus tends to be very, very dense. And because it's dense and small, it's very tough to grab it and hold it and to fracture it. So in these cases, my recommendation, or in cataracts that you find that won't be able to emulsify it, is doing small incision cataract surgery or 6. So in 6, what we do is do a superior peritomy. Then, because this bag is on tension, we don't want to have an Argentinian flag. So what we do is insert a needle, a 27 gauge needle. You can do it with a 30. You can do it bevel down or bevel up, with the anterior chamber closed, without viscoelastic. You go in and puncture the anterior capsule, and then you allow all this liquid to come out. You can press a little bit on the nucleus, and again, that liquefied material will come upwards into the AC and relieve that tension from the capsular bag. Then we create our incision. Generally, it's an incision that's created 2 millimeters posterior to the limbus. You could do it a frown incision. You could do a straight incision. You can do it a little bit larger, 7 millimeters. But what's really important with these types of incision is that you create a pocket that has, again, a wider diameter next to the limbus and a shorter one at the incision. Then we continue our case. We'll put some trip and blue. We'll put in some viscoelastic. And as you can see, as I inject my dispersive viscoelastic and then cohesive, here we want to press on the anterior capsule so more liquid comes out. And then we find where we did our little incision with the needle, and you're going to see that more of this liquefied cortex is coming in. Then we inject more cohesive viscoelastic. We want to press on it so it doesn't radialize, and then we will be able to do our rhexis. We use the 2.2 to do our central incision, and here I'm aspirating more of this liquefied material, and as I aspirate it, we see our nucleus, our dense nucleus, coming into view. Here with 6 or M6, we want also a large capsular rhexis again, we want to bring that nucleus into the anterior chamber, and so we can extract it. This technique, I'm going to tell you, I learned from my friend Santosh Bide from India, and in one of our Orbis programs in Ghana in 2019. He gave me a lot of tips to do it. So what we want to do is trying to extract this nucleus with cohesive viscoelastic. So as you can see, I'm injecting a lot of viscoelastic, separating and bringing that nucleus into the AC. Again, this is not a very large nucleus. It's a very dense one, but it's not very large. And the trick of 6 is the creation of the wound. And again, we could have a whole webinar on 6 and how to create it. But once we've created, extracting the nucleus is it's very easy. So 6 has the advantage of an astigmatic incision because we're working posteriorly to the cornea. Basically, the induction of astigmatism is compared to a 2.2 or 2.6 millimeter corneal incision. Again, so it has that advantage, and it has the advantage of being a self-sealing wound, and it has the advantage of enabling us to remove the cataract without fracturing. What I've also tried is going in and fracturing the lens in 2 with the chopper, and that allows it to come easily through the wound. So now it's not necessary to close that wound. I like to do it again, but it's not necessary because we created a tunnel, so it is an astigmatic and self-sealing one. So here we see again how our case ends very successfully, and this is the first day post-op. Here we can see our stitch that we did with a nice and very clear cornea. So to conclude, dense cataracts are tough cases. They're really challenging. Always do either regional or general anesthesia. In these cases, you should prepare yourself for complications. You might need to end up fixating a lens to the sclera. You might need to do vitrectomy. You might need the help of vitreoretinal surgery. So prepare yourself for that. Always use regional or general anesthesia. I like to use subtenons, as I showed, because it doesn't increase the pressure of the eye. And protect your endothelium with dispersive OVD frequently, as often as you want. If you're doing phaco emulsification, if you're doing extracap, or if you're doing M6, again, you can use any type of OVD. Do chopping techniques, horizontal, I prefer over vertical, as the strain on the zonule is less. Use high vacuum, medium to high power, and high flow rate for a stable AC. We don't want to have surge when we unocclude the tip. And again, plan beforehand, make sure that you're going to be able to do it. And if in doubt, if you have any doubts, convert to an extra cap, as that will make your case very successful. So I want to end up by thanking all of you for being here today. I want to thank Orbis for creating the opportunity to show you how to approach these very dense cataracts. Thank you very much. So I have some questions over here. What are the phaco settings that you used? I showed them high vacuum, and again, high flow rate, and medium to high ultrasound power. It's not dangerous to hydrodissect such a hard cataract? Yes, that's why I said initially that hydrodissection should be done with low amounts of fluid. Again, you inject it because you're not seeing the wave going behind the lens. And so you need to do just a little bit of fluid to liberate it. And then you can go around. If you see it rotates, that's enough. The big problem with hydrodissection is if you create what we call a capsular block, is that the lens moves forward and that the fluid has nowhere to go, so it ruptures the capsule. So again, if you do it very gently, you're able to hydrodissection. That's a very good question in this case. 6 with the scleral tunnel would have a better option than extracapsular. Yes, again, yes, if you plan for it, you can do it. That's what I showed 6. If you're very comfortable with that technique, you can do it. I trained doing extracap with the technique that I showed. So for me, again, doing that, it's basically the problem with extracap or conventional extracap is the astigmatism, and you need to know how to manage it, when to start removing the sutures to control that astigmatism. But again, 6 is an excellent option with these cases. Would you be able to display the phaco settings to use the chopping also? Well, I don't have it with me, but again, with the chopping technique, what you want is, as I said, having high power, longitudinal power, no torsional, because torsional will create a big opening. You want it just longitudinal to embed. You want to have high power and high vacuum. But in this case, you want a low flow. We don't want the liquid to separate a nucleus from a tip. So again, high power, high vacuum, rapid aspiration, because we want to embed and have a dynamic rise the ray, so we create a good vacuum. If you use not a peristaltic pump, but a vacuum pump, obviously it's easier to do that technique. So that's what you should do when embedding yourself in the nucleus. Your technique for soft cataracts, a very, very good question. And I think we have time. Let me see if I can show you my technique for soft cataracts. So this is the technique that I use for cataracts between N3 to N6. The soft cataracts, it's called a Dodick pre-chopping technique. This is Dr. Dodick, who invented the technique. He was my mentor at Manhattan Eye and Ear. And so what I do here is use these hooks to engage the nucleus at the equator and then bring them together, and you can fracture it in different pieces, 2, 3, or 4. So here we see the choppers. They're called the Dodick command choppers, and they have a blunt tip and a sharp inside. So you go parallel to the capsule, and then you verticalize the chopper, and then you fracture into 3 pieces in this case. Then this is a denser cataract, again, and then 5. So here we can see the fluid going around. And as I said, we introduce the chopper through our paracentesis and our main incision, go parallel underneath the anterior capsule, and we engage the nucleus. You don't have to go very to the periphery just to engage the nucleus, bring them together, and fracture it. Again, 2, 3, or 4 pieces is enough. This is a case I did at the Orbis Flying Eye Hospital in Panama. And this is an even denser cataract. So as you can see, I'm engaging the nucleus at the equator, bringing it together. As you can see, it's denser, and I fracture it in 2 pieces. And this is another one, and even softer. It's the same trick, hydrodissection. Here, as you can see, we see the golden ring. So that's where we have to engage our nucleus and fracture it again. And then you can continue to do your chopping technique. So that is my technique for soft cataracts. Have you used this snare for diving? No, I haven't, Julio. I haven't you sleep. In cataract with a leathery posterior plate, how to ensure a complete and thorough chop. Why do the chop cannot separate the sticky? That's a very good question, and I think I referred to it during the presentation. So if you can fracture the periphery, but the leathery posterior surface is still there, then you can bring this peripheral pieces and you can emulsify them, and you go all around and leave that leathery backward back plate as the last piece. And then when you've removed all this, it totally moves forward and you can emulsify it. There's another technique that I learned from a colleague from Brazil, Virgilio Centurion, who what he does a different technique. He does a divide and conquer, but he creates a central groove, either 2 or 4, and then he instills viscoelastic and he flips the nucleus around, leaving the posterior plate facing the cornea, and then he does another groove and he continues to emulsify. Again, what you can do what I said, removing the periphery and leaving that leathery plate for the end. Is aspirating lymphatic cortex without visco better than doing under visco? So, with a very, very good question. So, this technique, you can do various things for this, for these liquefied cortex. Here again, the risk is creating the Argentinian flag. So we don't want to create an Argentinian flag. So if we have the posterior chamber, the anterior chamber closed, when we do the puncture, if everything's closed and there's no fluid escaping through the wound, then what will happen is that the liquid will basically flow anteriorly, and because of the pressures within the nucleus and in the anterior chamber are basically the same, that there won't be any tension to create the Argentinian flag. That is why this technique using a syringe, but you cannot aspirate. If you go in and aspirate, then you'll create a gradient of pressure and you'll have the Argentinian flag. The other thing that you should do is put a little bit of BSS in the syringe into the needle, so there's no flow through the needle, creating that change in pressure. Another option is to do YAG before you take the patient to your YAG and do a little opening, and because the chamber is closed, again, fluid just will go from the inside of the bag into anterior chamber, and there's no risk of Argentinian flag. The other option is using viscoelastic, creating your wounds and your incisions, going in, putting a lot of dispersive and cohesive, so it stays within the eye, and going in and doing a little puncture, let fluid come, and do a spiral capsulorhexis. The problem with this is that because you have a gradient of pressure when you basically puncture, it can basically create the Argentinian flag. Does stop and chop technique still have place for hard cataract? A specular chip can be quite challenging. The answer is yes. Yes, you could still do it. The problem with doing a stop and chop technique is that you're going to use more ultrasound. So when I started my presentation, I said that there are 2 challenges. One is disassembling the nucleus, that you could obviously do fairly well with the stop and chop, but also limiting the energy delivered to the endothelium. So again, if you do that technique, your ultrasound times tend to be higher. How about using size MyLoop for dense cataracts? Any comments? I have no experience with MyLoop, but I've seen various presentations using it. The MyLoop is basically a nitinol a loop that fractures very well the cataracts. What I've seen from people who've done it is that when you do it, you have to basically with your other instrument hold it, because as you're pulling the loop, it tends to bring the nucleus anteriorly. So the answer is yes. There's another option, which is the ultra chopper. The ultra chopper was developed by Lucho Escaf in Barranquilla, Colombia, and it's basically it's like a knife that's attached to the ultrasound, to the handle of the ultrasound, and basically creates you can create a very fine a groove, not a thick groove, a very fine groove, because it's like a knife that goes in, and then you can go in with your choppers and separate the nucleus, and so that's another option. So MyLoop is another option, and the ultra chopper is another option. Alton used to produce the ultra chopper. They don't anymore, so I'm not sure if it's available in the market. And it works very well. I have one in my institution. He gave it to me as a present, and it works pretty good. Could you display your phaco settings for these cases, including those with chopping? I think we've gone through that. Thank you. You use as a dispersive viscoelastic. Yeah, methylcellulose works. Again, I haven't seen many studies using methylcellulose as a dispersive, so I couldn't assure that it'll work. You showed phaco settings for quad, not for chop. Yeah, we went over that again. Hello, how do you do the phaco chop? I think it was very clear how to do it. What do you think about stop and chop technique? We went through that already. How frequent 6 is done in Western countries? A good question. I think very little. I think in Latin America, there are the places that are done. Again, we tend to have dense cataracts like in Africa or in India or in Asia. So again, it is in our arsenal. Here in the States, I believe very little. Patients tend to have cataracts earlier. Is an IOL placement a part of cataract surgery? I didn't see it in cataract surgery videos. A great question. I shortened that because of time constraints. Again, at the end I showed a few, but all of them had an IOL surgery, in an IOL implanted. How long do you wait to remove the sutures after the M6? Generally, because it's an anastigmatic, the induction of astigmatism is actually very, very low. The conjunctival suture, I'll remove a week after, 8 days, mostly 15 days, because it tends to loosen up, and the corneal, the suture that you saw that I placed in 6. Sometimes I don't even remove it because it's under the conjunctiva. It'll reabsorb over time, generating basically no inflammation. In extracap that you saw, those sutures I start removing depending on the age of the patient, but generally at a month and a half, I'll remove the first suture in the steeper axis. Remember that sutures steepen the cornea, so removing that suture early will reduce the astigmatism, and then at 3 months I'll remeasure and I'll continue to remove them, the sutures. Generally, if you construct your wound well and you start removing your sutures at 1 or 1.5 months, then especially if you have high astigmatism. If you don't have astigmatism, or if you have low astigmatism, wait until the patient is 3 months out, because then it'll go against the rule. So if the astigmatism is high with the rule, you start removing it at a month and a half, 1 suture, and then the rest of them at 3 months. Which you prefer, small incision limbal or sclera? I generally go with corneal incision, except for those black cataracts that I'm almost certain that I'll have to convert. I say I'm almost certain, but I think I'll have to convert, so that I'll do a limbal incision. Do you bilateral mediate 6 for the dense cataracts? Do you do bilateral mediate 6 for dense cataracts? So again, that is a controversial topic. At the Barraquer, we've done bilateral simultaneous cataracts throughout the history of our institution. I was trained doing bilateral, especially extracaps in patients that are older. Again, you don't want to bring them twice, and the risk of infection is even lower. Remember, one of the increased risks of infection is corneal incisions. So if you're doing a posterior incision that's covered by the conjunctiva, the risk of infection is very low. So I think you could do a bilateral 6 for dense cataracts. Do you also use the Akahoshi pre-chopper to split the nucleus? Yes. If I find that I cannot fracture it and I find that the zonule is weak, I'll try to do a groove and use the Akahoshi to prefactor it. It works very well. Again, the downside is that you're using more energy because you're creating that groove in the center. So yes, the answer is you can use it. I used to do it back in the days when I was a less experienced surgeon. I used to do it that way. And if I find, and you saw in that video that I couldn't chop it, that I tried to create a groove and use the Akahoshi pre-chopper. What steps to be taken after the Argentinian flap? Already there. Very, very, very good question. So if you have an Argentinian flap, what you should do is make a little, so you have the Argentinian flap is basically like this. So what we'll do is create a little incision over here and go around to create a pseudorhexis, and do another incision here and go around. So you have 2 pseudorhexis, and we have the radialization where it was created. And that'll enable you to work and chop. A very good recommendation when you have an Argentinian flap is don't work and don't manipulate your nucleus in those extremes where the radialization is created. Because if you try to chop it over there, it'll basically continue the radialization to the posterior, and then you'll be in trouble. So always try to work over here where we created those pseudorhexis. Try to work over here, putting less strain in where the radialization was done. Julio Enrique de Leon. I had a few cases with weak zonules that I found during vertical chop, and I wonder if I'm applying too much force with the phaco tip. Please advise. Great question. I referred to this, that I prefer horizontal chop because when I do vertical chop, I find that when you're pushing and pulling, again, the strain on the zonules is greater. So when you're working horizontally, basically you're doing a movement that is horizontal, so it is centripetal. So the strain on the zonules is less, unless you pull a lot or push a lot. But again, that's why I prefer to do horizontal instead of vertical, because when you're doing vertical, you're pushing, and that creates a tilt of the whole back and lens complex, and that could create strain. So my advice is try to do horizontal chop in those cases. What chopper do you suggest for these hard cataracts? The one that I used, which is the Nagahara chopper. I like it a lot because it has a fine tip and the tip is not very long. So the risk of you going into the capsule and damaging it is very low. So the one that I use is the Nagahara. I'm going to type it, Nagahara chopper. Perfect. What is called this new loop? That's the My Loop. The My Loop is the one that we were talking about. As I said, I have not much experience with it. One of the reasons is the cost. Generally, initially when it came out, it was reusable. Now it's disposable, and again, the cost. I heard that it is now in Colombia, and the cost is not very high. So that is a very good option. What is your average CDE for brunescent cataracts? As I said, around 17. So if you do 17, if you do 20, don't lose your sleep on it, especially if you used a good amounts of dispersive viscoelastic. Can we use a ND-YAG, anterior capsulotomy preoperative, to reduce inside tension? Yes, I referred to it. Try initially to use low power YAG, 1 millijoules, and until you make a little hole in the center, and you'll see the fluid coming out through the AC, and that way you can do it. With high vacuum and high power, how low is your flow rate during direct chopping? Very good question. Around 30, 35, it should be when you're chopping. Again, you want low flow, you want anterior AC, but you don't want to repel the nucleus. So using around 30, 35 should be fine. Will you use a tension ring for loose zonules and hard cataracts, or simply go with extracap? I would simply go with extracap. I would simply go with extracap. Again, these cases, and as I said, if you have a pupil that doesn't dilate very well and a dense nucleus, always suspect that the zonules are weak. What kind of chopper do you suggest for being a phaco resident surgeon? I use the Narahara. I would use the Akahoshi. When I train my residents, the first technique that I train to use is a dividing concl technique, and creating a central groove and then chopping it with the Akahoshi. So Akahoshi has various choppers. It has the small incision, it has the universal chopper, and that is a very good chopper. The tip is not as sharp, and if you create a groove, you can fracture the nucleus adequately. Is phaco done in canopor capsulotomy? You can do it. You can do it. Initially, when Kelman debuted his phaco technique, they did a capsulotomy. Again, the problem with capsulotomy is that if you create lots of pressure, and if the way that you handle it, it could radialize and break. But the answer is yes. In these cases, like the one that I showed, that the rhexis is difficult because it's very fibrotic and it has folds, you could go and do a very peripheral canal-opener technique. What medication will you choose to give if there is edema after cataract surgery? You can use hypertonic saline. Again, always do preoperatively an endothelial cell count. If you have a dense cataract and there's a low endothelial cell count, go for 6 surgery or go for extra cap. You'll again avoid getting into trouble. But if there's edema, again using hypertonic saline will improve it. Generally, what we see in the post-op is that if the edema is centrally, it'll clear up. Generally, it clears from the periphery towards the center. That's what you should see. If the periphery is constant, it's not clearing, that patient will end up in an endothelial keratoplasty, most likely. But again, the answer is that. If we're to do ENIAC anterior to reduce tension, how long before phaco? It should be immediately. It should be immediately. Remember, as this liquefied material comes out, it can generate inflammation. So generally, what I would recommend is if in my institution we have the ND-YAG in the first floor, and the ORs are in the second floor. So generally, when the patient comes in, right before he goes into the ER, you do the capsulat, you do the ND-YAG, and then bringing up to the OR for surgery. Do you put CTR on loose capsules? I do. Especially if I see that I manipulated and I find that the zonules are weak, I'll do a CTR. As you know, CTRs come in measurements of 11, 12, and 13 millimeters. Generally, if it's an average sized eye, 12 millimeters should be enough. If it's a small eye size like an ophthalmos, 11, and it's a myopic eye, 13. And that's kind of the rule of thumb. Will you put a CTR in a Morganian cataract? Generally, Morganian cataracts, as I showed, this one was the capsules tend to be very stable. Again, with the Morganian cataracts, the challenge is the liquefied cortex and grabbing that nucleus if you were to try to emulsify. Any tips for dense cataracts with small pupil? Yeah, the biggest tip is use a pupil dilator. I like to use the hooks. I've tried the Malugin ring. I've tried the BVI. ring. But again, the easier to do and use are the capsular hooks. Oh, my pleasure, Francis. Any pre-op medications? Generally, I don't. Unless the patient has a high risk for infection, for example, diabetics, immunocompromised patients, or very old patients, I will start a fourth generation fluoroquinolone 3 days before surgery, 4 times a day. And that is my protocol. Then we dilate the patients with tropicamide and phenylephrine starting 1 hour before surgery, and we instill NSAID during that time 2 times before surgery. If patients have a risk of macular edema, for example, patients that have had previous vitreoretinal surgery for macular hole, I'll start Nevanac or Bromfenac 1 week before surgery, twice a day, and I'll continue it for 2 months after surgery. What would you do if the iris keeps prolapsing into the wound site? Generally, iris prolapse occur due to 3 reasons. The first reason is a bad construction of your wound, of your incision. So always tend to do it in 2 steps or 3. Create an incision, go lamellar, and then go into the cornea. That'll create, again, a valve that closes when pressure comes, increases. If you go directly in, you're more prone for the iris to prolapse. So in those cases, it happens because as the pressure increases within the eye, it pushes it out through the only opening that you have for the iris to come out. So in those cases, again, try to reduce the pressure inside the eye. Then you go into the phaco tip and you're good because there's no leakage and iris won't come out. In those cases, also do small amounts of hydrodissection because that'll push the iris out. And if it's an IFIS, either use phenylephrine intraocularly or use the iris hooks. That also helps to minimize it. And what I do is, if it keeps relapsing, what I'll do is I'll just reduce the pressure with my flat spatula, introduce the iris, and then put some dispersive viscoelastic so it stays there, and then cohese it. As the dispersive stays, it'll try to keep it in place. Iris hooks are better than rings. Again, that is a matter of comfort, what you're used to using, what you like. For me, I prefer the iris hooks. They're more versatile, and I like to use it. Because of big capsulotomies, how often do you use? A very good question. Very little, honestly. I only use it when I have a vitreous loss, and I want to make sure that it is not in the anterior chamber. So that's when I use it. I like to really instill very few things into the eye, just what's necessary. If definitely I feel that there is that the lens is not staying in place, then I'll put some myostat or pilocarpine. But the other thing that you can do is put a bubble of air in the AC. So you put some air in the AC, that will push everything backwards, and then you hydrate the paracentesis, and the bubble reduces in size, but it keeps the lens in place. So that is a very good option that I did when we did extra caps, and I still do when I find that it's coming forward. In intumescent cataract, when capsular has extended, will you straightforward convert to EC to extracapsular? No, the answer is no. I'll try to do, as I said, 2 brexes on the sides of the extension to try to even the forces inside of the eye. And what I'll try to do in these cases, I'll try to do a central groove or 2 central grooves so I can split it with the akahoshi away from where the extension was made, and generally I'm able to successfully emulsify it. When do you prefer M6 or AC over phaco in case of a dense cataract? Excellent question. I think that I would prefer it in when there's a low endothelial cell counts. I would prefer M6 or extracapsular. Or in cases that I see that there's phacodonesis, that the lens is moving, I'll straightforward go for an extracap. Unless the nucleus is not very hard, then what I will do is do a rhexis. Use my iris hooks to hold the rhexis in place. That it's easier in younger patients. You don't want to do a lot of tension because it'll radiate, and then I'll emulsify it. But again, if it's a complex case, I'll probably go for an M6 or extracap. Injecting air at the end of surgery, how would this affect them? You know, we've done for many, many years. Again, there's a lot of people nowadays saying that air is toxic for the endothelium. But again, I don't, you know, air is air. The cornea feeds out of air, so I don't think it has any problem. What is your suggestion for imagining posterior plate of a pronouncing cataract? I think I went over that. Again, removing the periphery and leaving that posterior plate for the end. Burn wound, what is your suggestion to handle it? So again, we have to be very aware when emulsifying the cataract of the sounds that your phaco is doing. If you listen, and it's something that you learn to do, but you have to have it, you know, you're used to listening when the tip is occluded, and when you find that something's not really working, stop. And that way you avoid burning. I've had in my life it was a severe wound, but it was a severe burn, but it was a burn. And the other thing that you see is that you start to see some like whitish material coming out into the AC, and that comes from the wound. So the first is to try to avoid it. Generally, what I find is that if it's really not doing, it's moving the phaco tip, it generally heat, and that's what burns the wound. If you already have the wound, so closing it initially is what's very important, and using an X suture. Basically, you go inside of the wound, and then you go inside the sclera, and then you suture it. That creates a loop, a 8-shaped suture, and then you can suture it and close it. And that suture shouldn't be removed before 3 months, because if you do it before 3 months, it'll start leaking. If definitely there's a big hole and you cannot close it, then you'll have to go for a scleral patch, which is a good option, either with cornea or with sclera, a very small 3mm patch. You trephinate it. And there's a technique that I published last year, which is called a limbal advancement, in which you make basically a laminar incision on the limbus, and you advance the whole block to basically close the wound. You have to again reshape. It's published. It's called a limbal advancement. It's published in the American Journal of Ophthalmology case reports. So you can find it there. Do you recommend using OVD for multiple times during phaco? Yes. Dispersive, as I showed, every 3 of CDE, if you have a machine that counts the CDE, or every half a minute or minute of phaco, stop with dispersive viscoelastic and continue. How long after AC-IOL insertion can we remove the sutures? The sutures you can remove, again, based on the age of patients. Younger patients heal faster than older patients, but again, 3 months should be enough. In terms of AC-IOLs, I'm against AC-IOLs. I'd rather you learn the handshake technique, Agarwal's handshake technique. It's very simple. Once you get used to doing it, it's a very good technique. You use a 3-piece IOL and fixate it to sclera. Or you can also, Ophtec has the artisan aphakic IOL, which is iris fixated. So by fixating to the iris, you can do it anteriorly or retropupillary. You can fixate it to the iris, and the risk of damage to the angle and the endothelium in the long run is much lower. So look into the artisan aphakic IOL, or learn a fixation technique into the sclera. I've tried Yamani. I think that it is not so reproducible. The tilt is not good, and we always have a lot of trouble inserting the proximal haptic. The handshake technique, it's very easy to do and works very well. Is there any beneficial effect of cold PSS for dense cataracts? As I showed in that study, yes, it lowers the temperature that's generated in the cornea. So the answer would be yes. It protects the endothelium because there's less thermal energy delivered to the cornea. Here it is. Okay, so this is a case of an ACIOL. This is why I don't like ACIOLs all that much. The cornea tends to decompensate. So this is the preferred technique. So I'm going to advance it a little bit like this. So what we do with the handshake techniques is you create two scleral flaps, 180 degrees from each other. There's another webinar that we could do, secondary IOLs in the future, but you create these two scleral flaps. Again, it's just like a flap like a trabeculectomy. It's a 3x3. And you create these two scleral flaps. You create two paracenteses also right above the scleral flap. You inject OVD. So first what we'll do is remove that Bykov lens. So here I removed it. Here it comes. Then you just disengage it and you remove it. Then we're going to remove the epithelium to be able to see. And then I'm going to use the hooks to be able to expand our pupil so I can see. Then I create these little tunnels with a bent 27 gauge needle. So it's a tunnel that's right in front. This mark is 2 millimeters posterior to the limbus, and then you create this little tunnel. Then we do with the V-lance, you do a sclerotomy. Again, 2 sclerotomies. Very important to see that you're able to introduce your instruments. And then a 3-piece IOL is inserted. If there's vitreous, it's important to remove the vitreous that's there. You can do the vitrectomy through the sclerotomy. And here we have a haptic, and it's called a handshake because, again, you hand it. Here, let's go back. Here, I grabbed it, but you generally hand it with one hand to the other, and you sterilize those haptics. And then you introduce them into the tunnel. Argawal described this using tissue glue. I do it without tissue glue. You just go in and introduce it into those little tunnels that you created. You can see the centering of the lens is perfect. And then you can fixate the haptic with an 8-shaped suture, and then you close your incisions. And this is the post-op, as you can see. The lens is perfectly centrated. And then I did an endothelial keratoplasty, and that is how the case ended up. So that is how you fixate a lens. But again, that should be a topic for a future webinar. For extra cap, and I think this is our last question, what kind of OVD is ideal? Here you need to create space. Unless you have, again, the risk of traumatizing the epithelium is very low. So we want to create space. So a cohesive viscoelastic is ideal. Is it fixated to the tunnel and sutured also? Yeah, well, I fixated to the tunnel, and when I close the sclerotomy, I engage the haptic. So the answer is yes, but actually I've done it without suturing the sclerotomy, just suturing the flaps, and it sits very well and it's fixated very well. So it's not necessary. I do it more out of precaution. Well, I think that concludes our webinar. Thanks to everyone.